be opening up. There it comes. Let me get a slideshow up. And now, there we go. Okay. This smaller. Hello, 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 everybody. Charles says hi with a question mark. Okay. All right, let's look at kind of where we are here. I think I am ready to share the screen so you guys can see stuff. All right, yes, this is Teams, not Zoom. There we go. All right, so we do use the chat feature for you guys to put your answers to questions in, and any questions that you might want to ask, you can ask there as well. We do ask that you hold the side conversations to a minimum because it just adds a lot of traffic in the chat box and makes it hard for me to see people's questions as a result. So please do try to do that for me. I know sometimes it's, helpful. I mean, you think you're being helpful because somebody has a question and you know the answer to it, and you think you can solve that for us really well. And we appreciate the thought, but it does cause us to then sometimes miss people's questions and make sure that they were answered correctly. So, all right, that being said, we got our screen up here. You should be able to see the slides. And we are doing physiological integrity today, subtopics, basic care and comfort, and physiological adaptation. So first and foremost, this is an old slide. We don't need that anymore because we're in Teams. We just haven't gotten it taken out of this particular presentation, evidently. The first thing we do like to review with you guys is how the exam itself, the actual NCLEX exam, is broken down by topics, and it's the same way that your adaptive exams are broken down. So we know if you're a first-time tester, you're currently studying based on the body systems and some other specific topic areas like electrolytes or public health, et cetera. And so when you go to take your adaptive exams, it feels weird, right? Because you've been doing module quizzes and your case study quizzes based on the body systems. So you get lots of those questions on, well, all of those questions on your module quizzes from the body systems and topics that you've just studied. But your adaptive exams are comprehensive, number one. So there's definitely topics you haven't studied yet unless you're finished with phase 3. And they are also drawing the questions differently, right? Instead of by body system, you are getting the topics from all body systems, from all disease processes, from all procedures that we do, from everything that we encounter as nurses. It's divided up under these other headings: management of care, safety and infection control, which make up the safe and effective care environment, health promotion and maintenance, psychosocial integrity, and then physiological integrity, which is broken up into basic care and comfort, pharmacological and parenteral therapies, reduction of risk potential, and physiological adaptation. So it's a whole different animal, right? When you go to take your adaptive exams, and the NCLEX will be that way as well. And the content that is covered under those particular topic areas, those client needs categories, have specific volume of questions assigned to them. So management of care is the one that has the most. It's 15 to 21%. So fully 1/5 of your exam is from management of care. That's an important thing to recognize. The next largest category is pharmacological and parenteral therapies. Why? Because there's just so many freaking drugs, right? Right. So 13 to 19%, so nearly 1/5 again of your exam. So that's about 2/5 of your exam already right there, right? Nearly 40% of the exam. And then the next biggest topic is physiological adaptation, which is 11 to 17%. So another big chunk of the exam. So you're really looking at anywhere from basically 35 or 40 to 60% of your exam is in those three content areas. Then the rest of it is broken up into these smaller categories. Safety and infection control is 10 to 16. Reduction of risk is 9 to 15. And then the remaining three, basic care and comfort, psychosocial integrity, and health promotion and maintenance, are each 6 to 12%. So when we think about how we study, right, where do we want to focus and make sure we really feel strong? Management of care, right? That's definitely an area we want to be strong in. But the reality is that depending on your personal individual strengths and weaknesses, this breakdown may not look exactly like this on your NCLEX when all is said and done. Why is that? Well, because if your exam closes at 85 questions, then you are going to get the breakdown in this percentage of the lowest range of the questions, right? Because you're always going to get at least this many percentage-wise of the content areas. And if your exam closes at 150 questions, then you're going to be at the maximum length for all of the volume of questions. But most people don't hit that. Most people's exams don't close at 85 or 150 questions. They close somewhere in between there. And that means, let's say you're really, really good at safety and infection control. So every question they give you in that client needs category, you get it correct. You could end up with 10% of, let's say, I don't know, your exam closed at 128 questions. So 10% of those came from safety and infection control, the lowest level, because you did so good with them. But maybe you're not so great with basic care and comfort, and you ended up at the highest level of 12%. So this, quote, smaller section could be at least a little bit bigger on your individual exam than this, quote, larger section, because of where your individual strengths and weaknesses are. So just be aware that that kind of little tip can be made, but it doesn't really matter when all is said and done, because you have to pass all the sections, right? That's the way it works. And you have to be above the passing standard consistently for their ability estimate of your individual ability to be high enough that it's well above the passing standard, and it gives you a pass at whatever number the exam closes. That's the other thing. It doesn't matter how many questions you get as long as you've answered 85. But most people answer more. So don't freak out if your exam goes beyond 85 questions, number one. And number two, you are not required to answer all of the questions. So if it goes beyond 85, don't then flip your brain and think, oh, well, now I've got to answer all the questions. You absolutely do not. You just answer however many it ends up giving you. So you just take your time on every single question until the exam closes. And it's going to close at some point, but definitely at 5 hours. And you are not racing the clock. You are not trying to beat the clock. It doesn't matter how long it takes you. You know the exam will close at 5 hours. So no matter what, it's going to close at that point. You will not be there for 3 days. Okay, it's going to close at 5 hours, but it doesn't matter if you get there or not. It can close at 3.5. It can close at 4. It can close at 4.5. It can close at 4 hours and 59 minutes, right? That doesn't matter when it closes, what question number you're on. You just focus on answering each question as it comes to do your best on that question so you can get it right, and your next question will be harder. And that's your goal on NCLEX. All together, that's your goal. Get this question right so the next question is harder. Okay, next question. Get this question right so the next one's harder. Okay, next question. And you keep doing it until it closes. Whatever question number you're on, however much time that takes, it doesn't matter. Okay, so that's the big idea that we try to help everybody get by the time they get to their actual exam. But today we're going to focus on physiological integrity topics, specifically the physiological adaptation and basic care and comfort. So basic care and comfort covers assistive devices, elimination, mobility and immobility, non-pharmacological comfort interventions, nutrition and oral hydration, personal hygiene, rest and sleep. And physiological adaptation focuses on alterations in body systems. That's every disease you can possibly think of, right? Everything that causes an alteration in our body. Fluids and electrolyte imbalances, hemodynamics, illness management, medical emergencies, pathophysiology, and unexpected response to therapies. So those are the topics that are actually in these two categories. We do a quick review of your NCLEX questions. You do want to make sure you're aware of what the actual focus of the question you're being asked is. That's your topic, right? What approach are you going to use from a strategies perspective? And the style of the question, how it's presented, it can sometimes help you make decisions about what the right answer is for one part of the question based on what you know the right answer is for another part of the question. And then we talk a little bit about therapeutic communication, because even though, yes, it is a topic in psychosocial integrity, it's also a strategy that we use for lots of questions in a lot of content areas. And it is a particular kind of question. So when you get a therapeutic communication question, you want to use that strategy. Respond to the patient's feeling and tone, provide them accurate information, focus on the client, use silence and your presence to give them space and time to think through their options and their feelings about those options and voice those concerns or the direction that they think they want to go. Avoid the why questions or the yes, no questions unless we're asking specifically. Do you have a plan to hurt yourself? Are you thinking about killing yourself or somebody else? We don't need to explore their motivations for why they do things. We just want to focus on what they think, what they feel, and what their choices are. And we don't want to minimize their fears or concerns. We want to address them directly, right, by providing that accurate information. All right. Next thing is your 6 steps. What kind of question am I answering, and what is the actual question? Sometimes it's not clear cut. So you have to think about what exactly are they actually asking me to do here? And then what is the focus of that question? That's my actual topic, right? That's what I need to be looking for, keywords and clues regarding and knowledge that I need to be applying. And then I want to use the strategy that applies to the kind of question it is to eliminate incorrect options, and then review the remaining possibly correct answers to select the best choice. Remember that often NCLEX gives you more than one technically correct answer, and you have to choose the best one, okay? All right, here is question number 1. A client admitted with acute myocardial infarction suddenly displays air hunger, dyspnea, and coughing with frothy pink tinged sputum. What would the nurse anticipate when auscultating the breath sounds of this client? And so think about, what exactly are they asking me? What's the focus of that? Work through your 6 steps. Would the nurse anticipate hearing bronchial breath sounds at the lung periphery, clear vesicular breath sounds at the lung bases, diffuse bilateral crackles at the lung bases, or stridor in the upper airways? Okay, so I'm going to give you guys a good minute here to think about this and throw your answer in the chat. And while you're doing that, I am going to go and refill my drink so I can not be quite so scratchy sounding. All right. Let's see what we got here. Thought I saw somebody else coming into the lobby, but maybe not. All right, so our correct answer is, of course, number 3, right? Diffuse bilateral crackles at the lung bases. So most of you guys got this right. This is excellent. We know that those pink frothy pink tinged sputum, right? That's a very clear sign of pulmonary overload, pulmonary effusion, or congestive heart failure going into severe exacerbation, pulmonary edema. Thank you very much. Who was that? Raji gave me the word I was looking for, pulmonary edema. And so, that's what we want to hear, right? Because what's happening? The fluid from the blood vessels, from the capillary beds, is leaking into the alveoli, right? That's basically what it is. So the air sounds all bubbly and crackly like Rice Krispies. It's a cereal that we have here. Hopefully you have it there too. It's because it's wonderful. And you can mix it with marshmallow and make Rice Krispie treats. But it sounds like that, right? When you pour milk on them, they go snap, crackle, pop. And that's kind of how the crackles in the lung bases sound. Now, a little bit about strategy here, guys. This question had 2 options that were basically the opposite of each other, right? Number 2 and number 3. Number 2 was clear vesicular breath sounds at the lung bases. And then number 3 was the diffuse crackles. So anytime you see 2 nearly or actually opposing options in your choices, generally one of those is correct. Generally one of those is correct. So think about those 2 always as your primary thought. Unless you can eliminate both of them as being wrong, probably one of them is right. Okay, because you literally can't go in 2 opposite directions at the same time, right? That's just an impossibility. So that's one of the reasons why we want to look for that option. All right, number 2, the nurse receives report on 4 first trimester pregnant clients. Which client should the nurse assess first, right? So this is prioritization, right? So think about your prioritization strategy. Should she see the client, number 1, with a hiatidform mole reporting dark brown vaginal discharge? Should she see, number 2, the client with hyperemesis gravidarum reporting excessive vomiting and weight loss? Number 3, the client with suspected ectopic pregnancy reporting abdominal and shoulder pain? Or number 4, the client with a threatened miscarriage who says, I am a Jehovah's Witness? So let me let you guys think about that one. All right. Again, you guys are doing pretty good here. Most everybody got this one right. A few got thrown off by some of the distractor words, but let's get in here and look at this. Our correct answer is, for this question, number 3. The client with the suspected ectopic pregnancy who is reporting abdominal and shoulder pain. So let's look at these others really quick first, okay? The hiatidform mole does have to be removed, but it's not life-threatening at this point, right? The patient's in the hospital. The only thing she has is some brown vaginal discharge. That's not unusual. That's an expected finding with this particular diagnosis. They are going to have to help get rid of it, right? They'll have to do a procedure to remove it because it's not a viable pregnancy. But there's nothing life-threatening there. Our patient with hyperemesis gravidarum reporting excessive vomiting and weight loss. That's the two primary signs of this particular diagnosis, right? We don't have any other information that this patient is blood pressure is super low, or any, heart rate is out of range or anything like that. All we have is that they have the signs that we would see with hyperemesis gravidarum, excessive vomiting and weight loss. So that's a normal finding with this diagnosis. And again, at this point, not life-threatening. The last one is a client with a threatened miscarriage. So they're not actively miscarrying. They had a threatened miscarriage. So they're in the hospital, probably on bed rest. And they say, I'm a Jehovah's Witness. What does that mean, right? What's important about that? Well, that's their faith that they practice. It's a offshoot of Christianity. And they have a strong belief in not accepting other people's body parts or fluids. Okay, so they believe everybody should keep their own body to themselves. And so they don't receive blood transfusions, they don't take organ transplants, and they don't give blood or transplant organs. Okay, so their part of their faith requires them to keep their bodies and other people's bodies separate, basically, as far as it goes for those kinds of procedures. So if she has a miscarriage and she has sufficient blood loss, the fact that she's a Jehovah's Witness matters, because she's not going to want a blood transfusion. We're going to have to make sure we have precautions in place to help mitigate any blood loss, right? And that's why that's important. But again, it's a threatened miscarriage. She's not actually miscarrying at this moment, and there's no blood that we see. But we have this person who has a suspected ectopic pregnancy who is now reporting abdominal and shoulder pain. Those are two signs that an ectopic pregnancy could have ruptured, which is a medical emergency, right? This is the person who could die on you. So this is why we want to go see this person first, right? And assess what's going on with them, get their vital signs, all of those good, happy things, because that's what, that's our person that we're worried about, right? The others can wait until we see her. So with a ruptured ectopic pregnancy, the clinical features include unilateral abdominal pain, because it's typically one fallopian tube, low blood pressure, hypotension, dizziness, tachycardia from blood loss, because when it ruptures, they bleed internally. And the hemorrhage will fill up in the peritoneal cavity and irritate the diaphragm and stimulate the phrenic nerve, which causes the shoulder pain. It's referred pain, right, from the blood that's building up in the peritoneal cavity. And so that's the referred shoulder pain with abdominal pain from the rupture. And the bleeding is our clinical sign that this is a medical emergency. We need to get this person to the OR, right? All right, question number 3. A client suspects she is pregnant and comes for a prenatal evaluation. Which assessment findings indicate definitive evidence, positive signs of pregnancy? Select all that apply. So you have to remember, how do we divide up the signs of pregnancy? There's presumptive, there's probable, and then there's positive, right? We think maybe it could be, it's highly likely that it is, and then yes, we definitely know, right? So we want the things that are definitive evidence, positive signs of pregnancy. Would that be one? And this is select all that apply. Would it be one, is doing this? Okay. Cervical softening on examination. Number 2, fetal heart tones detected by a Doppler device. Number 3, positive serum human chorionic gonadotropin test. Number 4, report of fetal movement felt by the client. And number 5, visualization of the fetus by ultrasound. Other. Okay, so cervical softening on examination. Cervical softening is not a positive sign of pregnancy. It is a presumptive sign, okay? Um, Knowing what it is not, I mean, okay. So presumptive signs are signs of pregnancy that are self-reported by the client, and they may be related to other medical conditions and therefore cannot be considered diagnostic of pregnancy. Probable signs are signs of pregnancy observed by the HCP during assessment. So the cervical softening is a probable sign. So I take that back. So cervical changes, positive pregnancy tests, objective things, right, outside the mom. And they are still, though, possible that they could have some other cause. So something else can cause a person to have a softened cervix, okay, besides just pregnancy. Number two, the fetal heart tones. This is a positive sign, right? Positive signs are those things that are conclusive evidence of pregnancy and cannot be attributed to anything else. So they include things like discernible fetal heart tones, ultrasound visualization, and fetal movement felt by the provider. So external to the mom. So that's our fetal heart tones and the report of the fetal movement, the visualization of the fetus by ultrasound. So the fetal heart tones, yes. The positive serum human chorionic, that's another probable sign. It's an objective thing, but it could be caused by other things, right? There's other things that can give you a positive pregnancy test. Report of the fetal movement felt by the mother, that is a presumptive sign because only the mom can tell you that, right? You don't know, you don't have any way to verify that she felt it. Okay, so that makes it a presumptive sign. And then visualization by ultrasound. So our correct answers were 2 and 5, right? Those are the only two that are completely external to the mother and verifiable by somebody else, right? And so fetal heart tones can only come from a fetus, right? If we hear them through a Doppler device, then we know for sure, yes, there's a baby in there. And if we visualize the fetus by ultrasound, we see it in there, yes, that's definitely a baby, right? So that's what we want to go by. Okay. Good evening, Bill, nice to have you. Let's see, number 3. All right, so here is our resource for this. You may want to screenshot this slide, guys. If you're not at maternity yet, you will then be able to pull it out when you get to that module. And if you're past it, then you know it's a good way to look back, right? So our lovely Aglarel Buat, who's one of our instructors, she did the maternity presentation that's in Learn Upon. And so this is from her presentation, and I love the way she did this, right? Presumptive means subjective. Only the mom can tell you, right? It's things that make us think we're pregnant and cause us to go to the doctor, right? So they have amenorrhea, so their period is absent. They're really tired. Their breasts enlarged, enlarged breasts. They get sore breasts. They have urination is increased. They feel the baby movement of the fetus, but sometimes that can be gas, right? Or something else. And then they have emesis and nausea, right? Morning sickness, the first trimester. So that's our presumptive signs. The probable signs are objective signs that other people can recognize, but they could be attributed to something else. So your positive pregnancy test, the returning of the fetus bouncing back when the uterus is pushed during palpation. That's called ballottement, but that could be a tumor as well, right? Tumors can do that. An outline of the fetus can be palpated. A Braxton Hicks contractions, softening of the cervix, the bluish color to the vulva, cervix, and vagina, and the lower uterine segment becomes soft, right? So, and those happen in order, right? So Chadwick's sign occurs first. So that's the increased blood flow to the perineal area. And then the cervix gets soft, and then the whole lower uterine segment becomes soft. So it's Chadwick, and then Goodell, and then Hagar's. So they actually occur in alphabetical order. I think that's a helpful thing as well. And then they have an enlarged uterus. And then, of course, positive things means there's absolutely nothing else it can be but a baby. Fetal movement, electronic device detects the heart sounds, delivery of the baby. You can't deny it was a baby then. Ultrasound detects the fetus, and you see visible movements of the baby by the healthcare provider or the RN. So we see the little hand or the little foot pushing on mommy's belly, right? That's how we know for sure. Yes, there's a person in there. All right. Question number 4. A client is 48 hours post-abdominal aneurysm repair. Which assessment by the nurse is cause for greatest concern? So she sees all of these things. Which one bothers her the most? Number 1, diminished breath sounds in unilateral and bilateral lung bases. Number 2, hypoactive bowel sounds in all 4 quadrants. Number 3, urinary output of 90 milliliters in the past 4 hours. And number 4, warm extremities with a 1+ bilateral pedal pulse. We got to think about this. Lots and lots and lots of folks are getting taken down the sideways path. All right, here we go. Big surprise for many of you. There's a handful of you guys that have gotten this right, a few of you that are off the beaten track, okay? So here we go. Big reveal. The correct answer is number 3. Urinary output of 90 milliliters in the past 4 hours. All right, so a lot of people were choosing number 1, diminished breath sounds in the bilateral lung bases. This is a client who had an abdominal aneurysm repair. Okay. Yeah, Jane is like, why? What? Why? Because 2 days ago, they had an abdominal aneurysm repair, big open surgery, right, to the midline of the abdomen. Okay. So that is a painful surgery, number 1. Number 2, it's general anesthesia, which takes a couple of days for most people to recover from. But this is a person who does not want to cough and deep breathe, right? Does not want to cough and deep breathe. So we're teaching them, here's your incentive spirometer, splint your incision. You need to do your coughing and deep breathing to help them re-expand their lungs. But just 48 hours after the surgery, it's not unexpected that they might have diminished breath sounds, right, in their lung bases. It doesn't say crackles or bronchi or any of that stuff. It's just diminished. So not unexpected, just 2 days after a general anesthesia, abdominal major surgery, okay? The same thing with number 2. I don't think anybody actually picked number 2, but hypoactive bowel sounds in all 4 quadrants, again, the same thing. General anesthesia slows everything down, so they may still have some of that there, right? Number 4, some people chose this because of that 1+ bilateral. They're like, oh, that's not good perfusion to the feet. Well, we don't have anything to compare it to, number 1, but the extremities are warm, right? So blood is getting there, right? The extremities are still warm. But number 3, the person has 90 milliliters of urinary output in the last 4 hours. Minimum urinary output is 30 milliliters per hour. So in 4 hours, they should have at least had 120 milliliters. So this is poor perfusion to my kidneys, right? And for a major abdominal surgery, that's a concern, because what if they nicked an artery? What if, or a blood vessel in there? Or what if the, things are just still not flowing right? You're going to see that closer to the body before you're going to see it actually in the feet, right? But the 1+ is probably related to the fact that the kidneys aren't being perfused either. Why? That's why there's low urinary output, right? So, right. And so, yeah, we should be worried of perfusion. And if we had been given vital signs, that would have been helpful, right? But we weren't given any vital signs. We had to go with what they gave us, right? That's one of the tricky parts as well. And Patrick says that's how NCLEX is tricky, right? So yes, it definitely is. So Catherine, I don't be surprised. You're not the only one who was likely confused, right? Oh, and somebody says I mistook the warm for possible infection, right? That they were warm. And so we have to think about, right? Warm is not necessarily hot, right? Or temp or febrile, right? So we have to think about what is really happening in this situation. What do we expect to see in a client who's just 2 days after a large major abdominal surgery, right? So I'm glad to know this was a helpful question for you guys, right? To think about, like, oh yeah, minimum urinary output, right? We have to be concerned with that. All right, question number 5. The nurse who is caring for a client with acute diverticulitis will immediately report which finding to the healthcare provider? Number 1, abdominal pain has progressed to the left upper quadrant. Number 2, hemoglobin of 11.2 grams per deciliter. Number 3, lying on their side with their knees drawn up to the abdomen and the trunk flexed. Number 4, a white blood cell count of 12,000. Which one of these is of most concern? Like, oh, let me call the doctor about this one. Okay. So most of you guys are getting this one right. So that's very great. Our problem here is the abdominal pain that has progressed, right? Has progressed is a good keyword to be like, oh, there's a flag right there, right? Has progressed to the left upper quadrant. But we always do look at all of the answer choices and we have to think about what do they mean, right? That's the second step in our clinical judgment model. These are my signs and symptoms. They gave me the cues. Now, what do they mean? So a hemoglobin of 11.2 is a mild anemia, right? It's a mild anemia. And people with acute diverticulitis can have some rectal bleeding or GI bleeding that's associated with that. It's typically mild, but it can result in a mild anemia. But this is not so low that we think they need a blood transfusion right away, right? So I'm not necessarily calling my doctor. They're probably watching that, but I'll need to call my doctor about it. Lying on their side with their knees drawn up and their trunk flexed. Well, diverticulitis is painful, number 1, and frequently drawing up into this fetal position does help relieve the pain to some extent. So this is not an unexpected position to find your patient in. And your white blood cell count of 12,000. This is a mild elevation from 10 to 12. And it is common with diverticulitis because of the inflammatory and infectious kind of symptomology that occurs with that. So 2, 3, and 4 are all not unexpected findings with acute diverticulitis, but abdominal pain that has progressed to the left upper quadrant, this is a sign that the patient could have, right, some perforation have occurred, their peritonitis is happening, which is potentially fatal, and so it needs to be reported to the physician because it's expanding, right? That has progressed was our key word. Expanding area of pain is a hallmark sign for possible peritonitis, right? So that's why we want to call our doctor. All right, time for that wonderful case study. As you all are aware, hopefully by now, unless you just started the program and you hadn't gotten there yet, your case study questions in Nurse Achieve, both in the case study quiz and on your adaptive exams, as well as on your actual NCLEX, will have 6 questions always, okay? In Question Clinic currently, we're in the process of revamping Question Clinic. So currently we only have 5 questions. So a couple of these, either 1 and 2, 2 and 3, 3 and 4, 4 and 5, they are merged to give us only 5 questions, but we still follow this process, right? This clinical judgment measurement model, which aligns with our handy dandy nursing process that we all know and love. So we want to recognize cues, decide what matters most, what bothers me here, what do I want to make sure my doctor's aware of, what do I think they mean? So then based on what I think they mean, what's my hypothesis and what's the priority hypothesis? And then based on that, what would I like to do for this patient? And then what can I actually do or will I actually do? And then did it make a difference, right? That's how we want to work through our clinical judgment model. All right, so CP is a 51-year-old woman who reports to the outpatient clinic today. She tells the nurse that she wishes to secure employment as a food handler and is required to show proof of a negative MAN-2 test. She reported that she came to the clinic 2 days ago to undergo this test and has now returned to have the nurse evaluate her reaction. CP lives at home with her husband and 2 children. She has no known medical history, but she admits that when she was a child, her mother had TB, but she has not tested positive before. Okay. So her vital signs are 97.9 Fahrenheit temperature, which is 36.6 Celsius. Heart rate is 85, respiratory rate is 34. Her blood pressure is 100/66, and she has an SpO2 of 97% on room air. So having this background information about CP and this set of vital signs, which items will the nurse include when teaching a new nurse at the clinic about the MAN-2 test? Select all that apply. So really our question here isn't about CP. Our question is about the MAN-2 test. What's true about the MAN-2 test, right? That's what we want to know. So number 1, it is a tuberculosis skin test that uses purified protein derivative, also known as PPD. Number 2, the skin test is done subcutaneously to produce a pale elevation of the skin called a wheal. Number 3, clients must return 72 hours after receiving the skin test to have the reaction on the arm interpreted. Number 4, a TB blood test is the preferred method of screening people who have received the BCG vaccine. I forget what that stands for. It's not blood, it's something else, somebody's name. The BCG vaccine, which is the vaccine against TB. Number 5, if a client returns to the clinic more than 72 hours after the skin test, the test needs to be repeated. Okay, so which of these is our correct answers? Push my button. A lot of you are getting 2 out of 3. A lot of you are getting 2 out of 3 correct. So that's good to see. Okay, so it is a tuberculosis, a TB skin test that uses purified protein derivative. That is a true statement. Okay, so that is something we would tell our new nurse. Number 2, the skin test is done subcutaneously to produce a pale elevation of the skin or wheal is not true. Okay, it's not true because it is given intradermally, right? Intradermally. So you have to read all of the words, right? Number 3, the client must return 72 hours after receiving the skin test to have the test interpreted. That is also incorrect, right? The person has to return after 48 hours, but before 72 hours, right? So we say 2 to 3 days. So it has to be before the 72 hours, but after 48 hours for it to be read. The TB blood test is the preferred method of screening for people who have received the BCG vaccine. This is true, okay? The TB blood tests are called interferon gamma release assay, or IGRA, and it is the preferred method for people who have had the Bacille-Calmette-Guerin vaccine. So that's the name, Bacille-Calmette-Guerin vaccine. This is the vaccine against tuberculosis. And if a person has received this vaccine, they do not ever take a MANTO test because it's guaranteed they're going to have a positive MANTO, okay? Because the vaccine gives them antibodies against TB, and that's what the MANTO test is checking for, right? The MANTO test doesn't check to see if you have TB. It checks to see if you have antibodies against TB, which means you were at some point exposed. Somebody has their hand up. Let me see if I can find them. I'm not sure who that is. See, who is that? It looks like Samuel maybe has your hand up. Is that you? Nope. Let's see if I can find you. Yeah, it looks like Samuel. Let me pull my chat box back up because I lose it when I come into the people and make sure there's nobody else. Yeah, okay. Chat box, where are you? You left me. There we are, more chat. Okay. Samuel, if you want to throw your question in right now, then maybe I'll be able to see it, okay? Because you have your hand raised. So if you have a question, go ahead and put it in there. And Abel says, why is number 3 wrong? So number 3 is wrong because the answer choice says the clients must return 72 hours after. And you have to return before 72 hours, right? Right? So it's 48 hours after or before 72 hours, right? That's why number 3 is wrong. Okay, so Sharon, for you as well. All right, number 4 is correct, right? So it'll the TB skin test will always be positive for somebody who has taken the BCG vaccine, so we don't give it to them, right? We just add, if you've ever had this vaccine, then we don't give that to you. We go draw your blood. And then number 5, if a client returns to the clinic more than 72 hours after the skin test, the test has to be repeated. Yes, that is true. It's only good up until then, right? Up until then, okay? So, all right. So whoever has their hand raised, if it's Samuel or if it's somebody else, please go ahead and throw your question in the chat real quick now so I can get that question answered for you, or you could just put your hand down if you don't have an actual question. Just go back up there to the top where it says raise hand and choose lower hand, and that will let you put your hand down. All right. So that is question 6. So let's move forward. So here's some information about the PPD. You always want to use a tuberculin syringe with a 26 or 27 gauge needle, right? So a little tiny needle. You inject 0.1 milliliters, so 1/10 of a cc of PPD intradermally into the dorsal surface of the arm, right? So that's the inside of the arm, palm facing up. Produce a wheal, which is a pale elevation of the skin, so maybe the little bubble, and then mark it with a pen, right? Mark it with a pen where you made the wheal. and then instruct the client to return 48 to 72 hours after the injection to have the results interpreted. We typically just tell people come back in 2 days. And then if they're going to be later than that, they typically will call and say, hey, I can't get there today. What's the latest I can come? And then we'll say, okay, well, you got your injection at this time, then you need to be here before then tomorrow, right? So that they come before the 72 hours. And then use the area of induration, which is firm swelling. It's not redness, it's firm swelling when interpreting the reaction, and measure across the arm, right? So 5 to 9 millimeters, right? Millimeters is, so that's half to 1 centimeter, is positive in a person who is category 1. That means never, ever exposed, right? Never exposed. And then 10 to 14 millimeters is positive if a person is in category 2, and greater than or equal to 15 millimeters is positive if a person is in category 3. And I think this is a person who's like severely immunocompromised or something like that. Let me see if I have that in my notes to give you guys. Sometimes we remember to tell each other this stuff. Okay. All right, so an induration greater than 5 millimeters is positive in individuals. Oh, sorry, I had it backwards. In individuals living with HIV, which have recent contact with infectious TB disease or have a chest x-ray finding suggestive of previous TB, right? If they've had organ transplants or diagnosed with other immunocompromised conditions, like they're like chemo or something, okay? So the smaller induration of 5 to 9 centimeters, this is for people who are immunocompromised, right? That's a positive test. Number 2, an induration of 10 millimeters or more is positive in people who are born in countries where TB is common or endemic. So we will see that because there are some areas of the world where TB is extremely common. In people who have been IV drug users, who are living in high-risk conjugate settings like shelters, correctional facilities, or nursing homes, those with diabetes, cancer, and end-stage kidney disease, who are severely underweight, and all children and adolescents. So it has to be 1 to just under 1.5 centimeters, right? 10 to 14 millimeters is positive in that population. And then an induration of 15 millimeters or more is positive for people with no known risk of TB. So if you've never been exposed to TB, never been around it, it has to be at least 1.5 centimeters reaction for it to be positive, okay? So that's another slide you might want to screenshot. If there's a positive reaction to a PPD, we will then have the person get a chest x-ray, right? And once they've had a positive reaction, they will always have a positive reaction. So that means if a person comes and this is the first time they've had what is classified for them as a positive reaction, they get a chest x-ray, and then they have to get a chest x-ray every 5 years unless they become symptomatic, in which case they need another one, okay? So that's how we do that. All right. Question number 7. CP has returned for interpretation of their results. This is CP's skin test. So it comes out that she is this is 10 millimeters, this is 15 millimeters. So she is at about, I don't know, I would say maybe 18, 19, possibly 20 millimeters. So almost 2 millimeters, 2 centimeters. All right, so complete the sentence by dragging the appropriate responses to the targets. The test is blank and CP blank, right? So section 1, the test is positive, negative, or invalid. And then option 2, the blank 2, does not have TB, has an active TB infection, might have been exposed to infectious TB. Which of these do we want to choose? Let's get your answers posted. All right, somebody had a question here. What if the client comes after 72 hours? What do? We tell them, we're so sorry, you didn't make it before the time cutoff. We have to do the test over, and you'll have to come back 48 to 72 hours after this injection, right? So yes, you just do it again. That's all we can do. We typically do it in the opposite arm, just so there's no confusion. But that's another reason why we do circle where we gave it, just in case, right? So because I mean, if they've had a mastectomy or something like that, and there are no injections in one arm, you may have to give it again in the same arm. So you want to make sure you've indicated where the first injection was versus the second injection. Oh, y'all can't see the slide. Let me reshare. Sometimes it just likes to go out. I'm not sure why. There we go. All right. Hopefully it's back up. All right. I'm seeing a lot of good answers here. So for her, let me get me down to the bottom here. I'm just making sure I haven't missed any other questions. All right, good job. All right, so CP's test is actually positive, right? Because she's in that middle category, right? She's been in an area where TB is common. She was exposed as a child, but she's not ever been sick, and she's never had a positive test before. But she's greater than the 10 centimeters, all right, the 15 millimeters. Sorry, I'm getting back to greater than 15 millimeters. So her test is positive, but it means that she might have been exposed, right? It's not positive enough for us to say, yes, she definitely has it. Number one, she's not symptomatic, right? Typically, you know, if you have TB, if it's active, you have symptomatic. So we have to say that she is possibly been exposed, okay? All right, so now they want us to click to specify if the assessment item is consistent with a latent TB infection or an active TB infection. So this question isn't about CP, really. It's about TB itself, right? As a topic, as a knowledge. This is really a knowledge question. This is basically a select all that apply. Is it TB or is it not TB? Yes or no? They're just asking you to fill up both of your buckets. Is this a yes bucket question answer or a no bucket answer? So looking at each of these, does not have any symptoms of TB. Would this be a latent TB or an active TB? Cannot spread the disease to others is number 2. Number 3, the TB bacteria has multiplied in the body and is contagious. Number 4, in addition to a positive skin test, they may have abnormal chest X-ray or positive sputum culture. Number 5, treatment involves less medications over a shorter duration. And number 6 is commonly seen among people with HIV. And number 7 requires long-term antibiotic treatment. So I do these generally by saying, if you want to just post answers for one side, right? Latent TB is this, or active TB is this. That helps us to just kind of differentiate. You can do both if you want. It's up to you, right? But basically, this is like a double select all that apply. Which ones go in which box? Okay. All righty. So if they do not have any symptoms, right? No coughing, nothing, no night sweats, none of that. It is going to be latent TB, okay? If they cannot spread the disease to others, it is latent TB. If the TB bacteria has multiplied in the body and is contagious, then it's, of course, going to be active TB, right? Because if it's latent, they cannot spread the disease. So contagious means it has to be the other one. In addition to a positive skin test, they may have an abnormal chest x-ray or a positive sputum culture. Okay, that is going to be active TB, right? Because if it is latent, they're not going to spread the bacteria in their sputum, right? It's not going to be there. If they have treatment, it will be shorter, less medications, and over a shorter duration. That's going to be latent TB. If it is commonly seen among people with HIV, that's again our active TB, right? Active TB is common among people with HIV. Why? Because they're immunocompromised, right? And immunocompromised makes you more likely to get opportunistic infections. And then requires long-term antibiotic treatment is active TB, right? So 3 for latent and 4 for active. All right, question number 9. Now we're going to talk about the medications, right? This is going to be a great one to screenshot when we get it all filled out, because I will tell you, TB medications are very, very common on your NCLEX. So the medications that are used to treat TB are associated with different side effects. Identify which of the following findings are relevant to the medication listed by clicking which side effects apply. More than one selection may be chosen for each item. Okay, so side effects of rifampin. Do they include red or green color blindness, gout, red or orange body fluids, peripheral neuropathy, or clinical hepatitis? Isoniazid, I never can say that one. Does it come with any of those side effects? Pyrazinamide, does it come with any of those side effects? And then ethambutol, does it come with any of those side effects? Okay, so some options: red, green color blindness or gout, red or orange body fluids, peripheral neuropathy, or clinical hepatitis. Each of those drugs may have one or more of those. So let me let you think about that. We'll give this one about a minute and a half. So we are running over a little bit today, but I want you to have some time to think this through. All right. Let's see. Red, green color blindness and rifampin? No, it has red or orange body fluids for rifampin. Isoniazid has, sorry, it also has clinical hepatitis. Isoniazid has the peripheral neuropathy and clinical hepatitis. Pyrazinamide has gout and clinical hepatitis. And ethambutol has red, green color blindness and clinical hepatitis. So they all affect the liver, right, and cause liver inflammation. So they can all cause you to have hepatitis, but they each have one of the others. Okay, so rifampin causes you to have red or orange body fluids. Acylazide has peripheral neuropathy. Pyrazinamide can cause gout, and ethambutol can cause red-green color blindness. But they all can cause clinical hepatitis. All right, number 10. CP, let's say from the drop-down menus, based on what we see here, what complication is most likely happening, and what is the nurse's priority action. Our list is pneumonia, emphysema, active TB disease, or latent TB disease. Based on her response, she has a positive reaction. Her mother had TB when she was a child. She's never tested positive before. So do we think she has pneumonia, emphysema, active TB, or latent TB? Let's take about 30 seconds for that one. Get a pretty strong consensus. A few people going off with other options, but most everybody's choosing the same. So our correct answer is latent TB disease, right? Because she's got a high respiratory rate. So evidently there's something going on in the lungs, right? And now she's got this positive reaction that she's never had before. So there's something going on, but doesn't appear to be actively sick, right? So we can get rid of that. And of course, we weren't talking about pneumonia or emphysema. We've been talking about TB the whole time. So surely it's not another disease, right? So our priority action would be a chest X-ray, a bronchoscopy, blood cultures, or apply supplemental O2. What do we want to do for her? You guys are on the money. Excellent. I'm going to wrap this up on a good note. All right, correct answer, as most everybody chose, is chest X-ray. Gives us the most immediate information, right? The bronchoscopy takes too long. She doesn't need that yet. The other things are not necessary, right? Chest X-ray tells us this is what's going on. If the chest X-ray comes back abnormal, then we're going to do sputum smear and culture, right? Not blood cultures, but a sputum smear and culture. All right, you guys. CP is hired under the condition that she completes her latent TB infection therapy and will immediately report any signs and symptoms of active disease to the clinic. She reports weekly for her medications and finishes her 12 weeks of therapy without experiencing any significant effects, right? And there's a link there for TB. Now, for future reference, once you're here, this will not be on your NCLEX, but just so you're aware, in the United States, for whatever reason, I don't know what it is, we do not administer the TB vaccine to people as a regular thing. I know they do in other parts of the world, but instead what we do is we test everybody for TB annually that is in healthcare, is in food service, is in any kind of situation where they could expose others, or that works in congregate areas like in corrections or nursing homes or those kinds of things. In addition, we test the people that reside in those congregate situations. So if they live in a nursing home or they are in a correctional institution, those people are all tested annually as well. If a person is positive for TB out in the community, they're given their medications, and typically we will have people be able to take their medications on their own, right? So our scenario here that she has to come to the clinic to get her medications is really not the way that we do it, like initially, right? If a person becomes non-compliant, we can have, or if they don't go to the clinic to get their meds, however it's set up, if they become non-compliant, we will send somebody to their house to give them their medications. And if that doesn't work, we will actually incarcerate people and force them to take their TB medications until the medications are complete, and then we release them. The reason for this is because TB is becoming drug resistant, right? That is the reason. Right? So make sure that you do it. Patrick is sharing his WhatsApp contact information for you guys. Oh, I'm glad, Patrick. I'm glad this is helping you. Yeah, we can see the medication slide again. I'll do that really quick. And I'm not sure, Bright posted dot. I'm not sure what dot means, but okay. But if y'all are looking for somebody to study with, Patrick just joined us in the program, and he's looking for study partners. All right, so just be aware that that is something that can happen here, just because we are worried about drug-resistant TB. Okay, so that is something that can happen. I don't know what the rationale is behind us not using the vaccine. We tend to be a very pro-vaccine country in general, so I'm not sure why the TB vaccine is not given in the US, but it typically is not. So, and here's your medications slide again. Oh, there we go. That's what Claire clarified that for me. Direct observation treatment. Okay. Thank you, Brad. I learned something from Bright and Claire today. Thank you. Mm-hmm. How does one know whether she is an attendee or a guest in the presentation? It depends on how you signed in and how you registered, right? If you registered as your name and your email address that we have as your email address with Avant, and you signed in with that email address, then you become an attendee. Otherwise, you're a guest because we don't have any way to match you with your sign in to the registration process. Okay. We don't typically go back, but I will really quick, just for this one time. On the NCLEX, no, you cannot skip a question. You have to answer a question to move forward, right? You cannot skip a question and come back to it later. Okay. Somebody wanted to see question 8 again really quick. So that's a good slide for you guys to screenshot as well. You're welcome, Jane. All right, guys, y'all know you are welcome to come back again tomorrow or Thursday. We do have 2 presentations on Thursday, so you have 3 more opportunities to see these same questions again if you want to. And we do appreciate you guys coming and being here with us. And we welcome you to keep coming every week, because this is your primary arena for answering questions and being able to get that direct feedback about why is her question right or wrong, and working through the 6 steps, right? That's the primary purpose of these presentations. Y'all have a great rest of your day.